Hello, you all, and welcome to the Live Expo for IBA Bible. I'm Dr. Izquierdo, and I'm here to talk to you about the repeated implantation failure. That's a topic that interests us a lot, and it's really concerning us when we are willing to become parents. First of all, let's talk about the implantation and how to go an ongoing pregnancy. We need to say that there are two very important factors in the fertility that may be involved in the implantation. The most important of them is the quality of the embryo. Having a genetically healthy embryo helps us to have an implantation. And then the second thing, and that's the thing that's going to make us busy in this presentation the most, is what we can do with our endometrial lining to make it firmly. And with these two factors, then how we have a dream team for you to get pregnant. When we say good quality, genetically healthy embryo, what are we talking about? As you all know, we all men and women have 46 pairs of chromosomes. Men X and Y, and women X and X, the less of them. And saying that a genetically healthy embryo, it means that we have done some tests to prove that those embryos have this 46 pair of chromosomes, XX or XY. If you don't do the test, there are some statistical tricks to see how we can work to try to, in some sort of way, see or prevail or be aware of how it's going to be the expected genetic quality of the embryo. Then we're talking about this, and that's related to the age. The quality of the embryos and therefore the quality of the eggs is related to the age of the woman. As you already know, women have been born with all the eggs that are going to be with them the whole life. That means that the elder a woman gets, the less embryos she's going to be able to produce because she's going to have less eggs. Those eggs are not just less, sent down out from, they're also from less quality. How come? Well, every single month, the woman, since her first period, has been trying to produce the best egg that she have in order to get pregnant. Therefore, with every single cycle that she would have lost the first best embryo that she had in the cycle. Therefore, the older the woman, the less embryos and the less quality they have. We have some statistics here for you published, and they tell us about how are the chances, or how are the statistics, the percentage from mothers given birth regarding their age. This is not just to prove, but to show you how actually the egg quality is, something to show you a tendency. After the years have been passing, we're trying to get kids to get pregnant, to have children a bit older. That makes that it will be usually, and it will be more frequent, that women will need assistance in reproductive medicine to have their babies. The best quality of the embryos are from the 20 to 30-year-old, and after that, they start decreasing. With women over 35, increasing the percentage of women that are willing to have babies. Therefore, they are increasing the percentage of women that will be needing some help in reproductive medicine. Let's talk about mother age and ovarian reserve. I already told you, the older a woman gets, the less or eggs she's going to have, and the less quality they're going to have. There are two factors that allow us to see or to forecast how good is going to be a cycle with a woman. One of those factors is the AMH, anti-mutant hormone, and the other factor is the follicle count. The AMH is not other than an hormone that the follicles produce, and the higher the hormone, the more follicles that will be available in the ovaries, who could be stimulated, mature, and matured by egg retrieval. The anti-follicle count is not other than the number of follicles that at the beginning of the cycle seem to be possible or prepared to be mature in this cycle, therefore be able to retrieve at the end of an stimulation process. quality of the embryos. That's the cue. As I told you before, that's related to the age and to the ovarian reserve from the woman. Therefore, women in between 20 and 30 years old have the most or the higher ratio and healthy embryos. We mean that euploid embryos, that means that the chromosomal number and the chromosomal structures are right. After that, it decreases, and as you see, after 35, it decreases very rapidly. There's another curve. It's a bit different, and it shows you which and how big is the risk of getting a baby with a genetic disorder, that being called Down syndrome, Plateau syndrome, all those genetic syndromes. And as you see, the curve moves really slowly till you're 35, and after that, it grows exponential. That means the higher the age, also as well, after 35, the higher risk of having a chromosomal defected baby. Not only women have issues in this situation. We gotta say that 40% of the men also have a factor that's stopping pairs that are willing to have babies to have babies. This needs to be taken into account with really slow and taking care of that. I'm not saying that 40% all men have problems or issues in the fertility. What I'm telling with couples that are attending to reproductive medicine praxis, in those cases, 40% of them will have a problem, will be a male factor involved in this process. What's the male factor? Well, three things. First of them, productive sperms, men being not able to produce sperms. Second factor, men not being able to transport the sperms from the testicles to the ejaculation. And after that, quality of the sperms itself. Men produce sperms that are not from good quality in many factors. Structurally not good, they're not moving, or they have a high ratio and two factors. DNA fragmentation means the chromosomes that they are bringing in to the team, they are not good, therefore they cannot produce healthy embryos after that. The other factor is apoptosis. We are not allowed to see how many of the sperms that are going to be produced are already starting to die. That's what apoptosis means. Our cells in our body, they are programmed to die after some time, like we are as well. And therefore, in the sample, if there are a lot of sperms that are already trying to die, then we say that there's also a factor that could be a problem in the fertility process. What we can do with these results, since we told before, egg quality, sperm quality, making tests on the eggs and the sperms before we make some fertility process is not really wise. How come? Because testing one sperm, it means after we test them, we cannot use it anymore. The same thing with the eggs. After I test an egg, I cannot use it anymore, and then we're losing cells that we cannot use. Then we did a test, give us information from an gamete that we are not able to use. And the other thing is, this sample is not representative from the rest of eggs of the rest of sperms from the couple. Therefore, if we want to see how healthy the babies are going to be genetically, we need to make the test at the embryo. There are some clinics or there are some places where they're still making tests from day 3 embryo. That's something that we in our clinic, we do not recommend anymore, because if you remember a bit of this process and all of that you've been hearing before, you'll know that a day 3 embryo has just maximum 8 cells. If we need to take 1 to 2 cells from this embryo to test genetically how they're developing, we're already damaging a lot the embryo. First of all. Second of all, this sample will not be representative of the embryo. 2 cell tests is too little of a sample to make a separation about the embryo. If we have this embryo in the culture for 2 days more, on day 5, we're talking about 150 cells. Therefore, we're able to take 15 to 20 cells to make some tests about them, and then have a more representative sample who can tell us about the genetic quality of the embryo, and as well, we won't be damaging the embryo. Therefore, PGTA test in day 5, the most and the best. How can we work? We said already, equality, sperms, there's a possibility, PGTA testing, knowing that the embryo's quality is good. How we need to do it? That we need to admit IVF, oval stimulation process. This oval stimulation, you may already know, but I explain it again. You become hormones, so you can mature follicles that can produce eggs. After 12 days around, 12 to 15, we have some mature follicles above 50 millimeters that we're able to retrieve and see how many eggs there are. We'll perform ovarian punction in this clinic under a light sedation, and we'll retrieve the eggs. After we retrieve the eggs, we need to see how many of these follicles actually had an egg, and how many of those eggs were actually mature. The maturation of the egg must take place in the ovaries and cannot be done in the laboratory. That's why we can't just fertilize the eggs that are already mature after the retrieval. We make in vitro fertilization in this clinic. Regarding the quality of the eggs and the situation of the sperms, we decide if we need to do ICSI, IVF, mini ICSI, all these tests, or all these procedures or ways to work. That's something we decide always in the laboratory. After that, we put our embryos in the culture and let them evolve. As I told you before, in day 5, blastocyst, 150 cells, we can perform the biopsy, extracting a couple of cells, 15 to 20 from the embryo, and therefore testing genetically, knowing how the embryo looks. That's just a sample for you to see how everything looks. It's just a curve that shows how much DNA we have regarding the chromosomes and the number of them. Therefore, if we see that in some of the chromosomes we have more material than usual, then we can say that in this case, there's more than one chromosome, but more than 2 chromosomes from those, and therefore a genetic alteration. So, in women who we suspect that are going to have not that good quality embryos, our approach is a bit different. Other than doing a stimulation, retrieving the eggs, and right away testing genetically, in order to avoid costs and improving the chances of having more success, what we recommend is an embryo banking. What does it mean? We produce a bank of embryos. Therefore, we try to collect eggs, fertilize them, let them go to day 5, and then make the biopsy and freeze them. The ideal is to get at least 6 blastocysts that are independent from the age of the patient, in a very good chance of being one of them at least genetically correct. Patients who had the indication for embryo banking are patients with an AMH under 2 nanograms per milliliter, less than 6 antral follicles, or an age above 35. But as we always say, that's something that needs to be discussed with every single patient because every patient is different, and those are just generalizations for you to have an idea. We must say there are other options. If we see that the ovarian reserve is pretty low, that the possibilities of making an IVF are not good, and that we are not able to succeed, or we think that we can achieve some embryos, or other than that, we already tried and we didn't have any success. The other option is just to go further and do an egg donation. How does it work? We look and we change the variable of the eggs. We aim to get an egg donor who is going to be young, in our clinic under 30 years old, healthy, and therefore we simulate her to retrieve her eggs. In this situation, with our egg donor being younger than 30 years old, the ratio and normal blastocysts that we produce is around 60%, 60, 65, 70% in some cases, that without PGTS. That means that we could, in this situation, avoid the genetic test and make a fresh transfer. How that the egg donation program works. We have some legal obligations in Spain. 3 of the most important that I like to mention is, first of all, anonymity, to protect the egg donor and protect the future mother, we must undergo an anonymous donation. How come? A woman who has performed an egg donation doesn't want to have any link to the future baby. Therefore, staying anonymous protect her from babies in the future trying to contact her. She's just going to have another woman to have a baby, not herself having a baby. That's the reason why she needs to stay anonymous. On the other side, if the donation is anonymous, therefore the patient that received the egg is also protected. The donor won't have trace, will be able to trace the eggs and to get to you and have information about the babies. First case. Second principle that's very important is that we need to supply you with a woman that's physically similar to you. How come? Because this law is also an inheritance from the organ donation program. That means that we need to supply the most physically similar patient donor for the patient that we have. The third obligation is the Spanish law of EMBRYOS to make everything what's medically possible to achieve or to produce healthy embryos genetically. That means that we make a karyotype of the donor and we make as well, in our case, a hairs test to look up and screen for recessive inheritable diseases in the donors. That being done, and after some other tests, HIV, hepatitis, and syphilis, if they're healthy, that they can register in our database. We have around 500 women in our database, and after we make a selection, we come to 100 of them. Therefore, we take in account the preference of the patients, the look of the patients, and all these factors, and we come to a 20 number from our database. After that, we reunite ourselves in a medical committee, and with our criteria and the genetic matching, we select 4 possible donors. We list them in the number from 1 to 4, and then we contact them to see if they're available to perform egg donation. In our clinic, we believe that the fresh egg donation is the best way to go, and that's why we try always to synchronize the patient and the donor in order to make as well a fresh egg retrieval, a fresh fertilization with sperms, and a fresh transfer in the first attempt, if a PGTA is not desired. For patients that have a backstory that's carrying problems or have tried before to be pregnant, I want to go for the most sure process. Therefore, for those patients, also possible to perform a PGTA test before we make a transfer, also in the egg donation. Therefore, the patient is sure that she has the better chance of getting pregnant. How does it work with the egg donation program? We need a mock cycle and a real cycle. Those 2 cycles are intended in order for us to be able to synchronize donor and patient, in order for being able as well to have a fresh transfer. How successful we are? In IFP Spain, we have a cumulative pregnancy test. That means in the first attempt, 70% of our patients are already pregnant. After 2 attempts, 91% of our patients are already pregnant. And after 3 attempts, 97% of our patients are already pregnant. We must already say that we are not capable of making all of patients pregnant. There are still factors in the reproductive medicine that we still don't know. Therefore, patients that may have factors that don't allow them to get pregnant that we cannot change. We're talking now about pregnancy and endometrium that are friendly. What's an endometrium friendly? When is endometrium prepared to receive a baby? As you know from the cycle, after 14 days of estrogens, a woman will produce an egg that will leave the ovary. In the ovary, it will be a yellow body or a corpus luteum that will start producing progesterone. After they fight this progesterone around it, the endometrial lining will be genetically, transcriptomically prepared to accept an embryo, and the embryo can attach. That's what we call an implantation window. Patients that have already received transfer haven't succeeded on having a positive pregnancy test, may have a displaced endometrium implantation window that we can prove with some tests. In our case, we work together with the IGLS laboratory, and the test that we offer is the ER mapping, endometrial resistivity map, that allows us to tell if the receptivity or the implantation window in the patient is displaced, and therefore making some changes in the real cycle to transfer the embryo in the perfect moment. If we repeat on having problems making a transfer or succeeding in having a positive pregnancy test, there might be another factors that we could test. An implantation failure is pretty much the same as a repeated miscarriages. There are some other factors that we can test. Immunological diseases like antiphospholipid syndrome, the behavior of the natural killer cells and the Th1, Th2 balance in the endometrial lining. How does it work? Having an endometrial lining, having a receptivity proven, an endometrial receptivity window that's already proved, there are some other factors. It must happen an immunological answer from the body or from endometrial lining from the woman who accepts and allows these embryos to develop. Therefore, the natural killer cells play a really important job in this process, and they must do two things. One of those are there to avoid the embryo from invading the uterus of the woman and causing problem. Other of those are there to allow new vessels production in the endometrial lining so the baby can be supplied. And the other of those are there to produce antibodies that can protect the woman and the embryo from an infection. Another factor that are important is the KIR polymorphisms. They're in some sort of way to explain, there are groups of people that react to other groups of embryos. There are some tests that are possible to be done to see which group of people we are and which group of embryos we might accept, and therefore transfer those embryos that are proper for these patients as well. The immunological issues, as I told you before, we can in our clinic test, make a biopsy for the endometrial lining and see how these immunological cells populations are behaving in the endometrial lining, and therefore adjusting the therapy regarding what's missing or what's exaggerated, and treating you properly with what you need in order for you to get pregnant. That test is the IMAP test, immunological mapping from the endometrial lining. Conclusions. The key for the successful treatment is having a healthy embryo and having a good team that's working for you, the laboratory, the technique they use, robotic or robotized culture process are very good, and they're working on preparing the endometrial line to have the best chance of getting pregnant. All being said, I would like to introduce you a bit of how it goes here. How can you work with us? How can you get in contact with us? Then you can, at the end of the presentation, I'm going to give you a film where you can have a contact number or email account where you can just contact and say, okay, I'm this patient, I'm interested in working with you. That being done, one of our assistants is going to contact you and ask you some questions about your specific case. With all this information, we doctors are going to be contacted in order to program a first visit. Then you come to us, we can see this here, or we can organize in this COVID situation a virtual appointment through Skype, Zoom, or other media, and then we can get to know each other. With your information and with our criteria, we can perform for you the best possible plan. That will get ready to have the embryo, the way of the egg donation with your own eggs. We go all the way to produce a healthy embryo to PGTA, egg donation, or PGTA, your own eggs, or none of them because you're not indicated for that. We prepare your endometrial lining. We make all tests to make sure that endometrial lining is perfect. then you come to get transfer. After that, we make you some treatment recommendations to the 12th week of the pregnancy. And after the 12th week of the pregnancy, you consider your ongoing pregnancy and will let you under the care of your obstetric specialist in your country or here in Spain as well if you're coming from Spain. That's me again. That's my picture. And the other thing that I would like to do is to present you a couple of cases so we can go together through the whole history of how we treat operations. So first case for your woman, aging AMH under 3 nanogram per milliliters and an anti-follicle counts for 2. The patient has already had 2 pregnancies and 2 aborts, 2 previous insemination cycles and 2 previous IVF cycles. In this patient, what we could attempt would try to do an embryo banking in order to produce embryos that we can test genetically. We did so. In this case, we made the PGTA test from the embryos that we achieved to produce. They were both genetically unhealthy, so we decided to go for the egg donation. Single embryo transfer, positive pregnancy test, pregnant woman, healthy child, everything's happy, everyone's happy. The first case study, I'm just telling you about Down syndrome, Edwards syndrome, Patton syndrome. That's what the anomalies that we found on those embryos that we tested genetically. Case 2, 27-year-old patient, AMH for 3,5 nanograms per milliliter, outer follicle count for 20. She hasn't been pregnant before. She had performed 2 previous IVF cycles and got transferred in 3 embryos. That we decide to go for the IVF plus with PGTA. How come all this? First thing, the 3 embryos. That's not something that we're really willing to do here in our clinic. How come? If you remember a bit of the biology in the reproduction medicine, you will know that day 3 embryos don't belong in the endometrial lining. If you remember a bit back, you will record or remember that the eggs contribute to produce of the egg and the ovaries. Therefore, after that, the tube is going to catch it. The fertilization of the eggs is going to be taking place in the tube itself until the day 5 of the evolution of the embryo. They won't get to the endometrial lining. After that, I told you before, the endometrial lining will be ready in day 5 to receive a baby. Then putting back an embryo on day 3 is obliging this embryo to survive 2 days without attaching, and then first of all attaching. We believe that in the culture, the embryos are healthier, safer, and transferring an embryo day 5 that has already proved us that it's in the chance of surviving and also genetically healthy, it's the way to go. So these patients will retrieve 25 eggs, produce 8 embryos in day 5, and from these 8 embryos, 6 were genetically healthy. We transfer the first embryo, the beta was negative, and then we make some testing after that. We prove the receptivity. We discovered that the patient was pro-receptive on day 5 for progesterone. Then we make another test, make the EMBRYO again on day 7, and then we discovered that the patient was already receptive on day 7. We perform a new transfer and she got pregnant. Those are 2 cases showing you how we work and we can help you. Now I can just thank you for your attention. I'll let you my contact there. You can just through contact@ipspain.com contact us, send us an email, tell about your story. We can contact you back and involve ourselves in the process of helping you being mom and dad. Now I'll let you with the Q&A launch, and I invite you to write some questions. Let us all the information you now want to know after this presentation, and then we'll be pleased to answer your questions. Best regards, Dr. Hector. Bye-bye.